Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday evening edition. Tonight is Greg and I talking anterior segment grand rounds, the best of the rest. You know, sometimes we get a little ambitious when we put lectures together, we don't finish. So we're going to trail back and try to finish some things that we started earlier. So we're going to talk about some of these cases, and Greg and I will be bantering back and forth. And if you have questions, of course, we got the chat room and we're happy to do that. I may actually tread over a little bit of ground I talked about earlier, but with a different take. And there's some interesting or important things that we certainly want you to take home from this. Now, for me, in the past 24 months, I've been on some advisory boards with speakers for Santon and Bausch and Lomb, but all my relevant relationships have been mitigated. I have created my my lecture myself without any outside undue influences. Greg?
Joe, mine will be short and easy, the same, because I'll just cover it whenever I do my slides.
Very good. Well, I'm going to start off, and I think we're going to know what we're looking at pretty quickly and pretty clearly. And this is a situation patching in the emergency room. This is a 19-year-old female contact lens wearer who had a red, painful eye while wearing her contacts. Got so painful in the middle of the night, about 1 o'clock in the morning, she went to the emergency room where they, patched her eye with a swab of gentamicin after trying to remove a white foreign body from her cornea, which they were not successful in doing. Her initial acuity coming in, pinhole, was 2100, not wearing contact lenses. She had a lot of conjunctival injection, epithelial excavation, some dense stromal infiltration with a purulent discharge, and she looked like this. Now, one thing I want to share with you, so that she did come in patched. Her eye was patched, and when I removed the patch, literally, I had to take half a step back because a large amount of mucopurulent discharge dropped from the patch and her eye onto the floor, nearly on my shoes. Now we see there's a lot of purulent discharge, a lot of inflammation, injection. We have this paracentral infiltration. I can tell you right now, the epithelium is completely staining. It picks up not just a few punctate epitheliopathies, but it is fairly well excavated out. There's a very, very heavy anterior chamber reaction. And of course, she has a lot of corneal edema and some reduced vision. Now, I'm going to tell you that I didn't rush her back to my camera to take this picture. I examined her, I treated her, I cleaned her up. If I clean this away, within about 3 to 4 minutes, it would be back again like this, and I'd have to clean it away again in order to really well examine the eye. So I think that brings me, Greg, to polling question number 1. What is the most likely diagnosis? Is it a bacterial conjunctivitis, a corneal abrasion, a contact lens overwear syndrome, a hyperacute conjunctivitis, or specifically gonorrhea, fungal keratitis, bacterial keratitis, or I don't know. That's why I'm here. I want to learn from you guys. Looks like we're rolling in nicely. I think people have some good ideas. I think there are a couple of good possibilities that are challenging people here. Any comments before we end our poll, Greg?
Nope, it's nice and clean. I'll end it for you. I'll share it for you. And there you go.
All right. Well, we have bacterial conjunctivitis. We have few people talking about hyperacute conjunctivitis or gonorrhea. Half say bacterial keratitis, a couple other things in there. And I think that's what we always have to consider. When we have these acute infections, first thing to think of is bacteria. The cornea is involved, so it's a bacterial keratitis. But I do want to talk a moment about the hyperacute conjunctivitis, also, often caused by Neisseria gonorrhea. That's actually a fairly uncommon type of condition. Now, everything here is very acute. This doesn't really, in my opinion, Greg, share with me your thoughts. This doesn't rise to the occasion for what I call hyperacute. I'll give an example of what I saw of hyperacute. I had an 18-year-old male come in, literally had a bath towel dripping with discharge from wiping his eye. I couldn't even see the eye. There was so much discharge. I would wipe it away, and I only had a few seconds to really look at the eye before it was all covered again. And that is one that I'm going to culture. I can tell you, I certainly did, suspecting Neisseria, and it turned out to be Corynebacterium diphtheria. So I guess you can say the moral of the story is not all hyperacute conjunctivitis are necessarily gonorrhea. It can be other organisms as well. And another clinical pearl I always like to say is, exotic lifestyles tend to lead to exotic conjunctivitis. All right, so I think we probably would all kind of agree this might be a quote unquote corneal ulcer. Anybody out there, and you can use a chat room, who out there treats corneal ulcers? Anybody out there? Greg, okay, there's my chat. Just put in, do you treat corneal ulcers? Yes or no? Put it in the chat, please. I hear yes, 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 yes.
Joe, do you
Yay,
mind?
yes.
I'm going to stop the sharing, or did you want that back up?
What do you mean?
Of the polling, I had it unshared and then it got reshared.
Oh, no.
So
you can take it off.
Okay.
All right, virtually everybody is saying yes. Someone says not central. Okay, great. Please do me a favor and don't treat corneal ulcers. This is a term I want to strike from our vernacular. Do yourself a favor, do me a favor, do everybody a favor. Don't treat any more corneal ulcers. Treat keratitis. This is a kind of a very loose term that I've seen hijacked in numerous medical malpractice cases. We're too sophisticated for that. What we want to do, or what Greg and I want to encourage you to do is, when you see this, be specific, think out loud, think on the paper, think in the record. Ask yourself, is this keratitis? Yes or no? Is the cornea involved? Now, based upon your clinical experience, do you think it's infectious keratitis? Or is it non-infectious keratitis? And if you think it's infectious, is it microbial? And if so, do you think it's a fungus? Is it a protozoan? Or do you think it's a bacteria? And if you think it's bacterial, what one do you think it is based upon your clinical acumen? But follow this algorithm down as closely as you can. Now, if you don't think that it's infectious, is it a sterile keratitis? Is a marginal keratitis, infiltrative keratitis, peripheral keratitis? Is it a contact lens related infiltrate? Is it a contact lens associated acute red eye, a Clare syndrome? Be as specific as you can. Try to stay away from the term corneal ulcer. You want to be able to treat keratitis. And I'll give you an example. There's a big difference in the three things that we see here. Here's a small staining peripheral infiltrate in a patient who's otherwise asymptomatic. I don't think that we're going to consider that to be infectious. Now we have something with a little bit more involvement of innocent bystanding tissue. We have a lot of injection and anterior chamber reaction, relatively small, and a fair amount of corneal edema. You may think this might be on the border, but most people would consider this probably to be infectious. And I can tell you, since I've started doing microbiologic evaluation of all these corneal lesions, these are almost virtually always infectious. And there's a pretty big difference between what we see here, which is a very centralized infectious keratitis. So these are three things that may still, quote unquote, fall under the category of keratitis or corneal, or I should say corneal ulcer, but we can see there's a big difference between these three. And the reason I'm going to say, stay away from this term, I'll give an example. I was defending an optometrist in a medical malpractice case, and he had a patient like this, 16 years old. Take this infiltrate and move it here on the cornea. Contact lens wearing 16-year-old comes in with a little bit of an irritated eye, has an infiltrate, a little bit of staining, takes the contact lens away, prescribes Tuberdex. Kid gets better, kid goes back to contact lens wear. Several weeks later, same thing happens, comes back in. All right, same general area, hypoxia, a little bit of staining infiltrate, otherwise mildly symptomatic, takes the contact lens away, prescribes Tuberdex. Kid gets better in a few days, great. Happens about 4 times. Treated same way every time. The 5th time, it didn't look like this. The 5th time, it looked like this. Now, Greg, what do you think that optometrist wrote on every visit for all those situations? His diagnosis was
corneal ulcer.
Corneal ulcer. And the attorney said, "Doctor, is it standard of care to treat a paracentral corneal ulcer with Tuberdex?" And when they phrase it like that, it's not a good it's not a good situation. So we are too sophisticated. We don't treat corneal ulcers anymore. We treat keratitis, and we're going to be specific as to what we think we're dealing with. Greg, hit me with polling number 2, if you don't mind. So for this patient, what would be your drug of choice? And I'll go back and show you the patient. And you can left click and just move that over. Ofloxacin, ciprofloxacin, natamycin, moxifloxacin, gatafloxacin, besifloxacin, or samplifloxacin. And for those of you who aren't familiar with samplifloxacin, it's whatever fluoroquinolone you have on samples in your cabinet.
It's probably one of the highest prescribed.
Yeah. My favorite glaucoma medication is Sampligan or Sampliprost.
There you go.
Okay, number of people coming in. Lots of good options here. What do you think, Greg? You want to call it here? We're just about 80%.
Yeah, and I just have a question, and I hope I don't butcher the name. I'm going to say Kishore. When you say dilate, are you saying to dilate to look for something in the back of the eye, or are you saying that to cycloplege the eye? Someone put, I would do a duo of polymoxin and Cipro.
Excellent. And that's not a bad idea, and we'll cover that in just a little bit. All right. So we went all through that.
Oops, I guess I should share the results, or did you share the results?
I don't think I did. Sorry about that. So edging out is moxifloxacin, good medicine, good efficacy, highly available, good price. Some people like to use multiple medicines. There's certainly nothing wrong with that. Very good strategy. So when dealing with bacterial keratitis, we have to give a mind to doing some sort of microbiologic evaluation if there is some risk of visual morbidity. But of course, we start off with a broad spectrum antibiosis. Now, a lot of corneal specialists are still using fortified aminoglycosides and fortified cephalosporins. That has always been the standard of care. That was always anointed as the standard of care. There's really no scientific evidence that show the fortified medicines were any better than topicals. It was just when back in the 70s and 80s, antibiosis, was relatively unsophisticated, and what we had topically often wasn't really all that effective. So they went to fortified, But in the 90s, when the fluoroquinolones came out, they actually did a number of studies and showed that the fluoroquinolones, even the early ones, such as siloxane and Ocuflox, were clinically equivalent to the fortifieds that they were using. Moxifloxacin, gadafloxacin, they're not technically FDA approved, but they're highly used, and that's what most people tend to reach for. The levofloxacin, becifloxacin, those have been approved for infectious keratitis. Ofloxacin, ciprofloxacin also have been approved for infectious keratitis as well. But really, more people have moved off to moxifloxacin or gadafloxacin. But if you need, ciprofloxacin and ofloxacin are still very, very effective medications. Somebody mentioned dilation. Cycloplegic is a good option, probably a 1% atropine in these situations. Cold packs can be very helpful to reduce inflammation. So can steroids after you've given the antibiotics a chance to work. And a lot of people, myself included, like to prescribe vitamin C and doxycycline to inhibit the metalloproteases that are leading to corneal scarring. Greg, is there anything you want to add to this discussion here in terms of therapeutics?
The other thing I would add would be a cryopreserved amniotic membrane to your thought process here. Cryopreserved, I say, because it does say on the package insert indicated as dehydrated or not. So I would add to your keratitis, bacterial here, keratitis, amniotic membrane. Some of these newer biologics like Revise might be something that can help, calm down some of the inflammation. So those are just some newer things that are out there.
Do you typically apply a steroid to these eyes, and at what stage do you do that, Greg?
Bacterial keratitis.
Yes.
I would not add. The answer is I'm going to add a steroid whenever I feel that there's reversal in play here. So that nasty ulcer that you had shown in that upper, I guess, right hand picture, that's eventually going to need a steroid, but not right off the bat. We could, in a sense, I think you're going to probably talk about PCR testing that would help us probably out.
Yes.
To know what's going on. When I see reversal is the time that I would add a steroid. So
excellent.
Mark has replied in there a bandage contact lens potentially as part of that. So part of that regimen. Yep.
Or is Greg says the extra strength bandage contact lens of an amniotic membrane.
There you go.
All right. So polling question, do you culture in your practice, or I should say, do you do microbiologic studies in your practice? Frequently, rarely, or no? I think this is a fairly easy one. Responses are rolling in very quickly. Okay, I think that I'm going to end it and share the results. Some people do, 3% are doing it frequently, 20% will do it, but rarely, and 77 are not doing a microbiologic study of these patients, and that's pretty typical. Now, a couple of things having been, and I'm going to talk about malpractice later in another webinar, I think in February. But keratitis and malpractice, I have been involved in a significant number of cases over the alleged mismanagement of keratitis. Now, few people can argue if there's a good outcome. Some people still will, but if you have a good outcome, it's hard to argue that. But if you don't have a good outcome, all right, now you may have to face some difficult questions. Greg and I talked about the steroid use, once he sees the reversal. Yes, steroids are very beneficial in terms of any sort of keratitis, but that involves following a patient fairly closely. Now, if you're following a patient closely, steroid use generally will not harm you or the patient. somebody had mentioned earlier, always consider herpes and always consider an alternate diagnosis if the patient doesn't respond in a reasonable period of time. Now, most people are going to treat for bacteria. Now, if you have a case of an infectious keratitis that is not responding, and you refer to a corneal specialist or you refer to a tertiary hospital, 9 times out of 10, they're going to treat for bacteria again like you are. And they will start looking for protozoan and fungus. But we always have to consider the alternate diagnoses when things are not going according to what you think should be reasonable. We need to temper the time that a cornea needs for resolution as to when to do something different. I don't know about you, Greg, but I've had a number of keratitises recently, not only just infectious, but some of the neurotrophic issues or near neurotrophic issues that take a long time to heal. There's sometimes corneas don't heal overnight. But a couple of things I can tell you from medical legal issues. If you have a bad outcome, the first question they're going to ask, where is the culture? And the second question they're going to ask is, why didn't you refer to a corneal specialist? So these are all things that should be in your mind when you are appropriately treating patients with keratitis. Greg, anything?
No, I think that was a good walkthrough, but we did get a question that rolled in before we get too far away from doxy. It says dosage of doxy.
I would be using about anywhere from 50 to 100 milligrams twice a day while the patient's on topicals. Greg?
Yeah. So it's doxy is kind of like aspirin. It depends on what level you give it at, is what therapeutic dose you're getting. So like aspirin at 81 milligrams is just antiplatelet. And as you give it at higher dosages, you start getting the antipyretic, you start getting the the analgesic effect of it, and then you get anti-inflammatory. Doxycycline given about 25 milligrams a day is basically, like a steroid. It's anti-inflammatory. So if you're just trying to go for the anti-inflammatory, parts, 25 milligrams daily. But if you're trying to do, trying to kill a bacteria with it and have it assist, then you want to get it above that. So like Joe mentioned, 50 to 100 twice a day. If you're treating Lyme disease, it's usually 100 milligrams twice a day, but that's not an infectious keratitis. But there's just kind of the thoughts, whatever level you're giving it at. Low dose is anti-inflammatory, higher dose anti-inflammatory, and anti-infectious. So.
And vitamin C, about 1,000 units by mouth once daily. Now, looking at microbiological evaluation, the study just came out just a few weeks ago, looking at traditional cultures in vivo confocal microscopy, which virtually none of us have, and polymerase chain reaction identifying microbes. And it compared all three, and they found that traditional culturing, plating onto blood and chocolate were best for bacteria. Confocal microscopy outperformed PCR and traditional cultures when it came to fungus. And both confocal microscopy and PCR were better than traditional culturing when dealing with acanthamoeba. So what they said is it needs a multimodal approach of possibly doing all three, which is, I don't think, very, very reasonable. But we do want to talk about PCR, polymerase chain reaction. I said culturing, that's not really the right word. This is a very rapid and very specific diagnosis of infectious disease, including bacteria and viruses. It really can identify pretty quickly what you might be dealing with. I'm going to show you right now. This is my culturing in my practice. This is my whole culturing kit. What do I have here? Got a label maker to put labels on this transport media. We got the Steraflock, which is where I get my sample from. We put it in this biohazard. We ship it off. I call a rep for the company, and they arrange a UPS pickup. And this is the head of the Steraflock, which is what I use to obtain my culture. Now, of course, you can use anesthetics. This right here all right, is like a Brillo brush. You can debride a cornea with this. You can really get a good amount of scraping. You scrape it off, put it in there, break it off, seal it up, put a label on it, seal up, call for a pickup. They take it out to the lab. Within about 2 days, I've got pretty good turnaround time. And this is what we're looking for. These are all the things that PCR is going to test for. Aspergillus, EB, Epstein-Barr, herpes, Neisseria, toxo. The list goes on and on. Pseudomonas, Klebsiella, just virtually anything that we might come in contact with, it will test for. Now, I will give you a caveat. It doesn't do great with fungus, but it's pretty good. I mean, you can't identify fungus. It's not great for fungus, but it's pretty good for everything else. And this is essentially what comes back. This was one of my patients recently. He had staph species detected at 600,000 copies, a moderate growth, and it goes through and tells me which ones are it's susceptible to or not susceptible to. Caveat, they don't have a lot of ophthalmics in there. You know, the OP is the ophthalmic, you know, levofloxacin, moxifloxacin, but it will really identify pretty well and tells me if I'm on the right track. I find this actually very, very helpful. I had a patient who had a keratitis that wasn't responding terribly well. I had a patient on moxifloxacin, got it back, found out she had 3 bugs, one staph species and 2 anaerobes. One of the anaerobes was resistant to virtually everything, which is why she was not responding. The one thing that it did respond to was actually doxycycline. Put her on that, added that to the regimen, she got better quickly. So this is going to help you identify what you're dealing with. It's very easy to use. It's essentially the new generation Culturette. The company I use is Health Track, and it's healthtrackrx.com. I have no financial interest. It's on Dallas, Texas. It's about a 1.5 to 2 day turnaround time. They bill the patient or bill the patient's insurance. I don't handle any of that. If it's cash, it costs about $125 to $150 to do this. But of course, we have a procedure code 65430, scraping of the cornea, diagnostic for smear or culture. In my area, it allows $109. And these are the kind of organisms that when I scrape them, I find they're virtually all infectious. Greg?
Yeah, just as you know, you said, Joe, you're changing the culture. Kind of funny, I said culture, changing the culture of saying corneal ulcer versus keratitis. And I think we're so used to saying culture here, like as you have in the slide here, polymerase chain culturing. When you talk to these companies that do PCR testing, they're not culturing anything. They're basically, you're acquiring parts of that bacteria, fungus, protozoa, whatever it is, and then you're sequencing it and replicating it via a DNA sequence multiple times. So culturing really, as Joe said, is acquiring something and culturing it and growing it on all the different augers and medias that are out there. This is not anything that's doing that. You're literally acquiring a sample, a testing with that swab, putting it in the solution, and then they are replicating it through DNA sequencing to then identify the pathogen. So there's nothing really being grown here. So as we say, corneal ulcer versus corneal, keratitis, this is basically a polymerase chain PCR testing that's being done. So that was a slide, not of your PCR culturing back here. That was your PCR testing that's out there. So you're acquiring.
I still use the term until we can change the culture on cultures.
There you go.
Any other comments or questions in the chat room?
Oral doxy for keratitis? Question mark. That's the only thing that came in.
The answer is it is sometimes adjunctive. I have actually used it, but I've used it in situations when I use oral doxy on low dose. I'm trying to inhibit the scarring. But when PCR testing indicates doxy is an effective medicine, I will actually add that to the armamentarium as well.
Yeah, taking a little deeper dive into how it inhibits scarring is it inhibits at MMP9, which breaks down the cornea. So it's the MMP9 that it inhibits. So it's more when you're kind of using it here and Joe's using it, you're not really, maybe if you get some, antimicrobial effect, that kind of, I'd say would be bonus. Probably if you're using doxy, you're using it more for the anti-collagenous part of it. The scarring, the MMP9 of it. So.
Well, here's a case I call the found dinosaur. He's a 63-year-old male who complained of bailing over his right eye for about 2 days. He noticed it after playing tennis. He comes in, he's got about a 20/40. Now, he does have a history of having a laser tear, so he knows about retinal detachment. He's always worried. He knows, I hear bail. He's been warned. If you see cobwebs, spider webs, or veils, come in immediately. So he's always worried about a retinal detachment. Now, the cataract removal with a capsulotomy about 15 years earlier. This information is in his chart from his previous practitioner. Now, when I first started looking at him, what I noticed was an opacification behind the intraocular lens, but pretty clearly the old records say he had a capsulotomy. I also noticed he had a pretty white grade 2 anterior chamber reaction with some white blood cells floating through there. And his pressure was 32, fellow eye was 15. And he actually looked like this when I dilated him. So undilated, I saw, a pretty dense opacification, which I couldn't claim that was a posterior capsular haze because he didn't have a capsule. So, Greg, any thoughts about what we're looking at here? This white lesion that is now in his visual axis?
I would suppose that it's probably cortex that was tucked up in there, finally got a little bit of some type of aqueous, and then it kind of swelled like one of those great sponges that are out there. That would be I don't think it's nucleus, looking at it.
Yeah, regardless, he's got a retained lens fragment, and basically it found its way into a privileged area where it was relatively protected between the part of the capsule and the intraocular lens. And when he was playing tennis, it finally shook loose. But this is about 15 years later. And I was like, where was this thing hiding? It's like a dinosaur. So he really has a phacoanaphylactic uveitis, or more commonly referred to as retained lens fragment. This leads to inflammation and usually a secondary glaucoma, because this antigenic lens material gets left behind in the eye. These areas of cortex and nucleus, whichever the material may be, is usually enveloped by the capsule. So even though it's the patient's body tissue, it's never been exposed to the anterior chamber. So when it does get exposed, it starts this antigen antibody response. You get these macrophages that will engulf the material, and they're going to actually settle out and block the outflow. And this is usually a severe uveitis following cataract extraction. It usually happens fairly quickly. They don't use this stuff usually doesn't hide that well. Usually, if you find these issues pretty quick in the postoperative period, and sometimes can be confused with endophthalmitis, and sometimes they even call it a sterile endophthalmitis. So usually it's a complicated situation where they don't get all of the lens material out. When that happens, we call that a retained lens fragment. In experienced hands, it doesn't usually happen very often. Most of the time when we do see it, it's often in VA hospitals or training facilities where the ophthalmology residents are learning cataract surgery. Now, exactly the same thing will happen if a patient has a penetrating lens fragment or trauma, such as a dart in the eye or something that penetrates the lens. And when that happens, we use the term lens particle glaucoma to describe it. So these usually can hide between the IOL and the posterior capsule. And again, this privileged space, and it kind of hides from the antigen antibody response. But if it comes loose, or if it is loose after cataract surgery, we're going to get secondary open angle. There's no pupil block. Nuclear fragments are much more likely than cortical fragments to induce this response. It will induce a worse response. Now, our initial inclination in these situations are to either increase or use steroids, but it generally is not really that effective. They really don't provide a cure. It's only short term. Aqueous suppressants can be used, but overall the material should be removed, especially if the situation is involving a piece of the nucleus. Now, this patient actually was put on topical steroids and a Combigan. And ultimately, they actually yagged it and blew it up, and eventually it drained away. Greg, I'm sure you've encountered this in your career. What are your thoughts here?
Yeah, it has. Unfortunately, I worked at not unfortunate. I did work at an ODMD practice, and then unfortunately, not in our practice, but in town, there was a surgeon that didn't have the best hands, as we would say. And there were times whenever, you'd say, I'm going to digress and come back. You'd say, how could the surgeon miss, a piece like that? Because like Joe is not that one kind of moved. But my point was, it's the lens material. It's like one of those miracle sponges. Like when it's just a little piece of fragment, you really can't see it at the time of surgery if it's tucked up underneath the iris, and then it moves through the pupil as the dilation is coming down. And sometimes you'll see it in the anterior chamber. They swell to like 30 times. And then the next day, when we do the 1 day post-op, you can see it. Just like Joe's here, it was kind of tucked up probably in that capsule. They did the YAG cap. It slowly worked its way back. The capsule retracted. Then it got into the aqueous and it swelled up and created that antigen reaction that Joe was talking about. What I like whenever the surgeon will do is go in and with an AI, an aspirator, irrigator, and aspirator, and I guess an aspirate IA, and go in and then take out that piece, because they're going to have an anaphylactic reaction. They're a bear to kind of keep it quiet. You're cyclopleging the patient. You're keeping them on steroids. You're using the glaucoma meds. Yeah, they can yag and it eventually goes away. But I do like whenever the surgeons go in and remove it, because it just takes away the antigen. My last comment would be, that's why when Joe talked about that dart going in and you break that capsule, not only are you going to get that, that antigenic reaction, but now that lens is going to swell like 10 times the size. And that's why it becomes super dangerous for that lens. So I literally had someone get like an X-Acto knife through the cornea and out. I mean, they had a little bit of a Seidels. They were sealed, but they broke the capsule. And I literally called my surgeon and said, broken capsule, when can you do surgery? And they were like, we'll have it done by, 9 o'clock tonight, because once that capsule's broken, that lens is going to now start to swell. And that's what you have to get that out from. So those are my comments.
Excellent. Looks like we're caught up in the chat room. All right, let's move on to a 20-year-old female. Chief complaint, intermittent itching and irritation, both eyes for about 2 months. It's worse after she showers. She feels her eyelids are red and swollen all the time. Commercially available lid scrubs were not very helpful. Maybe she was just using baby shampoo. Medical history non-contributory. She's 20/20 in each eye, but has significant erythema in each eye, thick crusting about the lashes. Pressure's normal. Fundus is obviously normal, and she looks like this. And Greg, when you come across this, what are your initial thoughts?
Well,
this is a bilateral situation.
Yeah, this is something that's, if you want to say microbial or parasitic, there's something living going on here when you see this type of appearance going on with an eye.
So I think that brings me to polling question number 4, Greg. So what's your diagnosis? Is it Demodex? Is it anterior blepharitis? Is it a squamous blepharitis? Is it pediculosis infestation? Or is it psoriasis infestation? And I think people will ponder this one for a wee bit.
Another clinical pearl that I like whenever I see that type of presentation is these patients will probably have more symptoms in the morning. The pH of the tears shift. They wake up, their eyes are burning, their eyes, they're not able to blink away all, in a sense, you want to say, the toxins that accumulate, the biochemistry experience that's going on from this condition that's happening. So these patients usually have more symptoms upon awakening and for maybe like the first hour, as opposed to towards the end of the day. That's kind of a little clinical pearl. When I start having these patients coming in and asking, like, tell me all, my eyes burn, my eyes hurt, this and that, I usually say, okay, help me out here. Is it more in the morning or is it in the afternoon? If it's in the morning, it's usually some type of bug causing it.
All right, we're going to end the poll and show the results. Majority say Demodex. We have a few people that say bleph, pediculosis. 3 people said psoriasis. So let's look a little closer, a little more detail. And this is not uncommon to what we see with the scurf or the collarettes we might see with the Demodex, but it's a lot heavier, a lot more extensive. It's kind of going down the lashes. It's not really kind of stuck at the base of the lashes. So what we need to do is look a little more carefully. And what we see is there's the organism. This is not Demodex. This is a crab, and this is not pediculosis. This is actually psoriasis. And I'll we'll talk about what the difference is, but this is an infestation. We can see right here, there's the body, the very broad body. There are the claws holding on to the cilia, and there's some bloody fecal matter because it's feeding off its host. Now, I will tell you, without manipulating the eyelids in any way, this is the only organism that I actually was able to see. Now, when I roll the edges, I'm not saying evert the lids, but if I roll the edges up a little bit, there are about 24 live organisms underneath, right at that lid margin. This was the only one that was exposed, and this was in both eyes. And this is probably one of the heaviest infestations that I've actually ever seen. Now, we always use the term pediculosis. That's not really the right term. That's either the body or the head louse. Pediculosis corporus or capitis, and they're actually pretty mobile organisms. That's why you have infestations among school children. They're or campers. They're in close contact, and it does spread because they're very motile. Psoriasis is infestation by psoriasis pubis, which is a pubic louse. This stuff that we see here, eyelid infestation, is almost always psoriasis pubis. It's a very broad crab-like organism with the claws, and it holds on. It's about 2 millimeters long. Because it's so thick and broad, it really is less mobile than the pediculous species. Another nice example, you can see it here. This is far, far bigger than Demodex. Demodex, you need a microscope to see it once you epilate that lash. These organs are fairly straightforward, very broad organisms, but they're not very motile. So looking at the size of it, these are the crab louse that it will infest the eyelashes, and the pubic region. This is a pediculosis. It's going to be a lot more mobile, and these egg sacs will attach to the cilia. So they're going to be in areas where the hairs are within its grasp. Eyelashes, beard, chest, pubic region. Interestingly enough, the spacing of the cilia in the pubic region is very similar to that in the eyelashes, and it very much is the same ecological niche for these organisms. Rarely do the crabs infest the scalp. So pediculosis, good mobility, they can pass person to person with close contact, infected bedding. Psoriasis, slow moving, they really won't be passed unless the cilia is brought into close contact with other infested cilia. So it is virtually always a sexually transmitted disease. Greg, have you come across these organisms before?
I have, rarely, I don't know, 5 times in my lifetime that have I seen some type of, say, crab infestation. So,
treating them, there are a number of things that we have done. They've advocated they breathe through their body. So if you smother them, the eggs, which are often called nits, and the organism with a bland ointment, petroleum jelly, and keep it lathered on, it will smother them. Other things that will do it, cholinesterase inhibitors, physostigmine will poison them. Mucuric oxide will poison them. Fluorescein will poison them, actually, but not fluorescein from a fluorescein strip, but fluorescein from an angiography kit. Now, the nits or the egg sacs can survive a single application and continue to reinfest when they hatch. Now, removing these is probably the best way to do it. Forceps of all visible organisms and the nits, they can be put in an alcohol wipe, discarded, that will kill them. Interesting, if anybody's ever done this, this is very, very slow process to get them. They hold on. I can argue that if you put some ointment into the lashes, they slide off a little bit easier. So it makes it a little bit easier to get rid of them, but you're going to epilate a few lashes when you do this. They really do hold on very well. It's very, very painstaking, and it's very, very time consuming using a jeweler's forceps and a biomicroscope. Interestingly enough, this is where the term nitpicking comes from. People who are nitpicky or people who are very, very focused and very tight-sighted. That's where this comes from, picking off the nits or the egg sacs. There are medicated shampoos such as Quell, Rid, Nix. They're over the counter, but they're not for ocular use. They are toxic, and they can't be used in the eyelids or eyelashes. Interestingly enough, they don't actually have that warning on the package, but we don't recommend that for facial use. Greg, any thoughts?
Yeah, the thought that I had was, Tarsus, out the academy, you couldn't miss, Tarsus, and they're, in a sense, pre-launch of their TP03, which is used for Demodex. And I was just Googling it real quick. It's LOTILANER, Lotilaner. And it works on the GABA channels. I know that when killing the Demodex. And so I was looking to see if it would work for this. So that might be an off-label use. They certainly won't be able to use it, but it looks like that might be an off-label use once that gets approved. And they have a PDUFA date as of August 25th of next year. So we might going to have something for Demodex, but that might be an off-label use for this condition.
So, advocating removing as many organisms as you can, and then using petroleum jelly, bacitracin ointment. These are all going to be acceptable. Those egg sacs will hatch every 7 to 10 days, so you should watch the patients periodically to see if you miss something and they reinfest. All clothing, linens have to be washed, high heat drying will kill them. They should refrain from interpersonal contact until this has all been resolved. And they should probably be investigated for the potential of other sexually transmitted diseases, such as chlamydia, syphilis, gonorrhea, and even HIV. And they should, talk with their partners to have them evaluated as well. Now, here's a case we call I'm not going back there. This is when I was in academia. I was working with a fourth-year student who was examining an older male patient. And literally, she staggered out of the room and she looked visibly ill. And she said, I'm not going back in there. There were worms. I think I'm going to pass out, is what she told me. And not much really to set up. He's an older male patient, recently returned from a trip to Las Vegas. We take a look and there's the infestation. We can see the body right there. There are the claws holding on to the cilia. And we went through the same situation where we had her painstakingly remove these and eventually smother the lashes to make sure we got everything that we could. Discussed the sexually transmitted diseases, history, and advocated being tested for other STDs. So the whole adage of what happens in Vegas stays in Vegas isn't necessarily true. Greg, anything you want to add?
No, that's good. We got a question that rolled in that says, tea tree safe for eyes. So tea tree oil, is it safe for eyes?
Greg, you want to handle that one?
I will. Yeah, tea tree oil is safe for eyes, but it's just like everything, you got to get the right concentration. Tea tree oil is an antibacterial, antifungal, and antioxidant. So it's a naturopathic way of going after these bacteria and fungus, cleaning up the lids, used for Demodex, as in a Clearadex is what we use it for. I don't know the concentration that's in Clearadex. I know that there's a pad and I have them in my office, and then there's a foam. I don't know the concentrations. The foam is a little bit lighter. It's kind of more maintenance. So yes, but if you went and probably to the internet and bought tea tree oil and started to use that on the eye, sure, it's going to have that antibacterial, antifungal, antioxidant effect, but it's probably at 100%. Tea tree oil is probably a little bit too strong. So that would be my guess.
Pasha, where do you
Or my
procure
comments.
Bisostigmine? You can probably order that from medical supply house or a pharmacy. You would have to order it. It is an old glaucoma medication. It really isn't necessary. There's not much magic here. Bland ointment will smother them. That is fine. We don't need to poison them. Physical removal, that's all going to be good. And Thomas is thanking us. His eyes are fiercely itching right now. I mean, whenever I do this live, I can just watch the people in the audience start scratching their scalp. It's just natural. Greg, I'm gonna turn this over to you. If we want to, we can always come back here. I'm going to stop sharing and let you do your part, and I'm going to sit back and enjoy what you have to say now.
Good. And Thomas, we aim to please, so we are glad that we were able to please for you here. So, all right, Joe, can you see the slides?
I can.
Perfect. All right. So again, everyone, this is, Joe and I are kind of doing the best of the rest. This lecture came about when we didn't get to finish our other anterior segment. So, this is interactive and synchronous. And I told Joe I would go over my disclosures here. Just real quick, the content was prepared independently by Joe and myself. Here's the big laundry list of people. Again, you hear me say I don't do that to impress people. It's just so I can stay connected. Really nothing in this lecture financially or proprietary interest in any companies. I am a non-salaried affiliation with Pharmanex, PA medical director for Involved, healthcare registries, AMD, and diabetes. And again, everything that I mentioned today so far and then going forward is without commercial bias and doesn't claim any superiority. And I think you guys figured out half owner. I am going to be showing, that's why I asked who has an anterior segment camera. I think it was about 30 or maybe 20 to 30% that had an anterior segment camera. I find these to be awesome in the practice to be able to show patients, get compliance up, do follow up, and I'm able to do my lectures. So I use Firefly by Efficient. Again, there's other cameras out there. I'm not claiming any superiority. It's just, I'm just trying to mitigate all the text that I get afterwards. Hey, what camera do you use? That's what I use right there, Firefly. And that's what you'll see of these images. So with that being said, here's a 61-year-old man. Joe, kind of feeds off of one of your cases. So 61-year-old man, November 21st, 2019 is when I see him, and he's got blurred vision in his right eye. The patient states the vision has been blurry, unsure if it was caused by change in his script, scratches on his lenses. You know, thoughts on what you think going on as I read this case can go into the chat box. He's a patient with diabetes, hypertension, high cholesterol, and he has sleep apnea. He had cataract extraction in 2016, February 19th and the 23rd. Everything was pretty well, you know, normal, uncomplicated. He comes in here now. So there's his cataract surgery. He has been wearing this prescription, plus 75 minus 175, plus 1 minus 2. You can see the axes, his 20/60 in this eye. And I'm able to refract him to 20/20, but there's a little bit of a refractive shift. So the good news is he's 20/20, but he's now anisometropic. He's 3 years, 9 months since cataract surgery. So as we go through this case here, tell me what you think is going on. So again, 61-year-old man basically had cataract surgery. Now we're getting this little myopic shift, but he's pseudophakic. All right. Is it macular edema? He's got diabetes. He's had cataract surgery. Here's his right eye. Looking pretty good. Maybe a little vitreomacular adhesion. No drusen, pretty dry. Come over to this eye. Looking pretty good. Myopic shift from diabetes, but this is an anterior segment lecture. Cornea edema. All right, liking it. Endothelial dropout. I'm liking it. All right. Does it look like posterior capsular haze? Not seeing any haze on this patient. Fuchs, we're thinking cornea. I'm going to tell you that his cornea, I love it all. I don't see any cornea issues with this patient. Liking it, thinking that it's an anterior segment, focusing on that. There are this right eye. Here's the left eye. Dry eyes. Remember, it's how much of a refractive shift? Oh, $1.75 or 75 is $1.50. All right. So let's take a look. I put a little music to this when I was playing around on my phone. All right, everyone, look closely. It could be the right eye. It could be the left eye. Good luck. Okay. We don't have to see it again. And let's take a look. I'm going to start pointing something out here. This was my anterior segment camera. We did see it here, and Jeffrey has nailed the diagnosis of a capsular distension syndrome. So as we go through here, you can see the IOL. You can see all I did is I took this anterior segment, whatever this is, a linear, you can usually do angles with it. I just asked my technician to go grab the implant with it, and she does a great job. So you can see the implant here. You can see the capsule here, but here's the right eye. Look at the implant. Look at all this fluid back through here. And we can go back. I'm going to play the video. It's right here, guys. See the back of the implant? This is the back of the capsule. Look at all this kind of cloudy, smoky protein type. And I'll play the video here again. And plus I want to play the video again. 'Cause of the sound. You can see here that as I go back
All right,
and forth,
everyone,
you can
look
see
closely.
the
It could be the
capsular
right
distension.
eye. It could be the left eye. Good luck.
And what that has done is it's pushed the implant forward. It has pushed the implant forward and created a myopic shift. And that's what that is. The treatment here, as you can see, is a YAG cap. The YAG cap was done. No video here or no sound that I did on this one. And you can see after the YAG cap that the capsular distension is resolved. So this is what it looked like afterwards. Here's the right eye. Here's the right eye again. Here's the right eye before the YAG cap was done. You're just kind of releasing that fluid. It's not a common complication, if you want to say it. Once a year, once every year and a half, you kind of see it. Sometimes they're not as gross as this. So sometimes I'll see this little refractive shift happening. And it's just enough to create that anisometropia. So, we do YAG them and get rid of them when they happen. So good job, Jeffrey, out there with and David, I see it now. So sorry, I missed you, David. You said it earlier. That it says capsular bag distension syndrome. It's a rare complication of cataract surgery with the in-bag IOL placement, a syndrome that is characterized by this turbid, cloudy buildup of fluid in the posterior capsule. It's basically residual epithelial cells undergoing metaplasia, proliferation, producing numerous types of collagen and extracellular matrix, and that's why it's nice and cloudy. And you laser it off, and basically you just cycle, or you just use some topical steroids to control the inflammation. The implant goes back into place, and the glasses are usually going to be adequate because the implant kind of shifts back into place. So Joe kind of had a dinosaur of a case in a sense where you got that inflammation from that most likely cortex. And then you see what can happen here with this kind of capsular bag distension syndrome. So let's jump into polling question number 5 here. All right. How comfortable are you with neurotrophic keratitis? Very comfortable, or just, all right, guys, that's why I'm here. Help me with this condition.
Greg, as the questions are rolling in, here's something that people may be wondering. After the YAG has been done, does it go back to exactly the same prescription, or are they still going to be off a little bit? Do they need another refraction after that?
Yeah, well, my N of 5, I don't know how many I've seen. I'm not sure how many I've had to change their prescription. I mean, he went back exactly to his refraction. It might be a quarter off. Are we going to change it for a quarter? I guess it's going to be patient dependent. So,
but that's that for people who are co-managing patients with the YAG capsulotomy. That's why a patient, they come back if they they don't have maybe the wow factor of their prescription, like they're seeing much better. You may need to do a little bit of a check, re-refract the patient. There may be a shift from the pre to post YAG capsulotomy.
Yeah, this condition, this case came about was one of my docs in the practice. There's this, we kept creeping up over the years. Now it got to the point that it was anisometropic, and they're like, listen, I can't. And I walked in the room, and I've seen this, and I kind of had in the back of my mind what it was going to be. Just they gave the classic history of it, like everything's clean, I've looked everywhere, kind of that Fuchs, the cornea, I tested cornea topography, this and that. Just kind of went to the bag and said, okay, I see what's going on here. But they did all the work for me because they ruled everything else out. All right, let's see here. Help me with the condition is what most people are. And All right, so let's jump in and let's help. Let me stop sharing. Very comfortable, 3%. We got about a third of the audience that's comfortable, and the rest, about 66%, that is saying let's learn something about this. And so let's jump in here. So what I can tell you is what I've learned over the years of, and I've helped with Dompe kind of launch this medication that we're going to be talking about that treats this, or one of the medications that's out there, is, staying without pain. I have patients that come in and their eye is very painful here, but they don't feel anything over here. Right? How many times have we had someone come in? It's like, oh my gosh, my eye hurts. You put some fluorescein in the eye, they scratch their eye, and it is not even a millimeter. It's a quarter of a millimeter, and they're bent over in pain. But yet, how can this patient here, you put the stain in, and they're like, yeah, everything's great. That is not good, right? When patients have dry eye and they have ocular surface disease, and they're going through, my eye hurts and my eye hurts, and you're putting on tears and it's not really helping. And then their eye becomes less pain, but more stain. You're going neurotrophic, and neurotrophic is not good. So when I see this in the practice, or if I have this patient come in, it's been referred to me, and you put the stain in and they're like, yeah, my eyes feel good. I don't feel anything. That is not good, because this can now move into, to other cornea complications that's out there. So cornea sensitivity testing, there's a couple different ways to do it. And it's, you hear me say, like, if you want to get good at gonioscopy, when I did it, I was working at that ODMD practice. We were seeing 40 patients a day. A lot of them were post-ops. I would just say, hey, look, this is part of the post-op regimen. I'm going to numb your eye, take a look at their, look at their angle, and take a look around. It's wide open after cataract surgery. So it was easy for me to see all the structures and learn. And so that's how you kind of get good at things, is just do it and do it and do it. Now, cornea sensitivity, I used to do it before, like, okay, you're neurotrophic, but then what are my treatments? And now you have amniotic membrane, you got things like, Regenerize, but maybe they're not as efficacious as some other things, but you have to test. And what I've learned too is you got to kind of test the quadrants and central. So you kind of have to go superior, temporal, superior nasal, inferior temporal, inferior nasal, and go central, the quadrants plus central that are out there. And you're going to see what, there's different ways to do it. There's the Cochet-Bonnet type of tool that's out there that's used for studies, if you're in a study, but you can use things like, dental floss. I've heard people say about taking a suture that's been sterilized, cutting it and using it with a pair of forceps. I just like taking a cotton tip applicator out, grabbing it with my fingernails, pulling off, and it makes a little thread. And I just try and get like one little strand to be able to go and touch the cornea. So that's kind of how I prepare my instrument, if you want to say, for cornea sensitivity testing. So I did a few here, and I have a few that I can show you via video. You can see here, watch, touch, patient blinks, boom, touch, blink. I'm going to come over here to this eye and watch what happens here. I can literally almost write my name with that. And as I drag, the patient doesn't really feel it. Okay. So I'm going to play that again and watch what happens here. As I barely touch it with those few threads, patient, boom, feels it. Boom. Doc, quit touching my cornea. All right. That is a normally sensitive eye. I'm going to pause it right here. I'm going to show you what's going on with this condition. I thought this was an early dendrite, and that's what this turned out to be. So this is not like neurotrophic. This is neurotrophic keratitis, but it's the start of an infectious neurotrophic keratitis. This was a dendrite that came in super, super early. And I was like, is this herpes or not herpes? And watch now as the eye's not numb. This isn't fluoresce. This is just fluorescein in the eye compared to the other eye. You can see that I can just drag it across. So all I did for this patient was put them on just oral Valtrex and cleared it right up before I got a big outbreak. Now, this is another patient that came in, and this is more kind of your dry eye patient, or your neurotrophic keratitis. Again, you see the little wisp that I've created, and as soon as I'm touching here, I'm trying to hit the different quadrants, maybe I'm hitting their eyelid down below with some of those, and it makes them blink. But I tested kind of inferior. Tell me when you feel it is what I'm saying. I'm bouncing that off their cornea, and they're not feeling anything. So this is kind of how you test, cornea sensitivity. You want to do this test to be able to document in your chart that you checked for cornea sensitivity. I'm asking the patient, tell me behind, you can't really hear it, I'm touching central there. I might have them look down to kind of catch that superior. Tell me if you feel this. And, as soon as you touch a few of these fibers to that cornea, remember, the cornea is the most innervated part of the body, the whole body. It's the most innervated per capita that's there. So that's just doing cornea sensitivity testing. There's just a bunch of them here that I'm just showing you. Here you can see maybe there's even the cornea stain. Look, I'm touching centrally. The patient doesn't even feel it. I asked them to blink there. To kind of, just for the video, I'm going to pull the eyelid up and so, all these patients, yet another decreased cornea sensitivity. And, this is before oxervate treatment. This is where this lecture, this is, how to utilize oxervate in your practice is, here's a patient that comes in. This eye here might be more sensitive, right? This eye might be less sensitive. They might be complaining about this eye more than this eye. And if that's the case, this eye is more sick. Look at the neurotrophic, and if you want to say conjunctivitis, or the staining. Look at all the staining. Look at the cornea. This patient here might be saying, yeah, my left eye feels a heck of a lot better than my right eye. That is a sicker eye. That is not good to have this eye feeling better than this eye. That's another kind of neurotrophic way of thinking about what's going on. That eye is losing feeling, and then that's not good because all the feedback, and that's why this keeps getting worse staining over time. So we've kind of talked about it. I guess we'll just throw it up there to make sure that it's interactive and learning, which biologic is indicated for neurotrophic keratitis. Is it oxervate, Tepezza, Actemra, Avastin, or hey, you don't know, and that's why you're here. You want to kind of use education and further. Joe, thanks for launching the handouts. I guess I should have been doing that, but thank you for remembering.
No worries. We both forgot. You think we'd never done this before?
That's true. So,
and if you end up 5 minutes short, I've got two real good clinical pearls to share to wrap up with.
Okay.
If we
All
have
right.
time.
Okay. I'm just going to end this poll. I think everyone's nailing it. Just going to share the results. Yep, you guys are right. Oxervate is it. And I'm going to get ready for the next poll and move on. All right. So, after oxervate, this is what the patient looked like. Was it 100%? No. Was it a marked improvement? The answer is yes. Kind of getting to that root cause of the neurotrophic keratitis. So when it comes to oxervate, you do a grading system, and that's why if you want to, apply for this medication, the cornea grading sensitivity, it doesn't have to be really intense, normal, reduced, or absent. A couple of those might have been reduced. The other ones were pretty absent, reduced in all quadrants and centrally. Absent, inferior, reduced everywhere else. You just want to have that you did a cornea sensitivity testing and then grade the neurotrophic keratitis, which is the staining, right? So you can call it mild, which is stage 1. You could call it moderate or stage 2, and then severe is stage 3 that's out there. So when you're looking at neurotrophic keratitis, it's a degenerative disease. You hear the Mackey classification. It represents one of the ways to assess or grade neurotrophic keratitis. We probably see a lot of this in the practice, which is basically that punctate epithelial keratopathy. What happens is when it starts to, and this might be kind of grade 1+, once it starts to coalesce and you get that kind of persistent, that large epithelial defect, you start now calling it stage 2. And then you start getting that, in a sense, ulceration. You're starting to get the cornea to thin. That's your stage 3. So, here's just a bunch of Mackey classifications. I use it in the practice in a sense. I do cornea sensitivity. I have a pretty high end of using Oxervate in the practice. And you can see here, this is moderate stage 2. This here is moderate stage 2 by the Mackey classification. It's not really ulcerated. It's not really punctate. These are starting to, in a sense, coalesce and become those persistent epithelial defects. This whole area is here, but there's really no ulceration to call this one a 3. Here's another, this would be, say, reduced or absent in your staining, but these patients, they're hardly saying, "Oh yeah, my eyes don't feel bad." They've already gone past. They're neurotrophic. That is not good. That what's happening for this patient. So you're grading the cornea sensitivity. You're grading the staining that's with this cornea that's out there. And look, this is what I love about this medication is you can reverse this. It's kind of root cause. I like this medication because it's not like a steroid. It's actually the endogenous nerve growth factor. It's really cool. We're going to talk about that here shortly. So you're really getting to the root cause. So here's before and here's after using this biologic agent. So Oxervate was approved in 2018 by Diplomate Pharmacy. So pharmaceuticals, that's not misspelled. It's an Italian company. The dosing is 1 drop 6 times a day, basically every 2 hours. Here it is for 2 months, 8 weeks. The drop is not infused. It's not injected. Remember, this is a biologic. Biologics are huge. They're big. This is really the first eye drop that is a biologic or a manufactured biologic. There's storage issues with it. All biologics are really delicate. They're really complicated. They're like jet engines. They're not like small molecule drugs like aspirin. But the good news is there's really no contraindications. So with that being said, just to drive home that this is a biologic, what organism is used to produce Oxervate? Is it E. coli? Is it a Chinese hamster ovary? Is it COVID-19? Is it Staph aureus? Oh, a living organism is not used, or hey, that's why I'm here.
While the answers are coming in, Greg, or the poll is being done, there's 2 really good questions in the chat room.
Would the pain and neurotrophic keratitis return during Oxervate treatment? If so, how do you manage? The answer is yes, Jeff. Stay tuned to a couple of videos that I have to come, and then I'll tell you how to manage. Most biologics are expensive. How about Oxervate? Yeah, Oxervate's probably, if you look it up, probably $90,000. If you go to GoodRx, it probably says about $30,000. But that's because they're super, super complicated to make. One of the cool things that Dompe did with Oxervate is they created a foundation for patients. I have never had a patient denied for Oxervate. This is a difference here. This is a difference between the old phone of taking a tin can and a string and talking to someone, as opposed to a cell phone here like an iPhone. They both can transmit the voice, but one's a little bit more complicated. And that's how biologics are, and that's why they're so expensive. Because I'll end the poll, and the people are correct here, phoning a friend. They are using the E. coli as the agent. So basically, someone figured out the DNA sequence of endogenous nerve growth factor. Nerve growth factor is needed on the eye. DNA sequence, put it into E. coli, it spits it out, it replicates it, but it's another DNA sequence. The proprietary way now is to twist it up and make it look like endogenous growth factor. And that is super important, endogenous or just nerve growth factor, because we have this corneal nerve, we have the neuromediators that it supports, we have the endothelial cells. This is the cornea. It's the most innervated part of the eye. All these chemicals are talking to each other, and even the cells are talking to each other. And when you start to lose that nerve sensitivity, now things start to go awry, right? Things start to spin out of place when you lose that nerve being sensitive. And that's why that cornea cannot heal. You put a Procare on a bandage contact lens, but it just comes back because you're not treating the root cause of the neurotrophic keratitis. So the pathophysiology of neurotrophic keratitis, the loss of the corneal sensory innervation, damage trigeminal nerve, impairment of corneal sensitivity, and things, you get that big negative feedback loop, and you just can't get that cornea to heal. Impairment of the trophic supply, the trigeminal reflex. The patients, they didn't even know to blink. They get something in their eye or their eyes dry. They're just staring at the TV. They're not knowing to blink. And that's not good when you have neurotrophic keratitis that's out there. What I'd like to point out here is there's all kinds of etiologies. How about your glaucoma patients? We create neurotrophic keratitis all the time by using prostaglandins and alpha agonists and carbonic anhydrase inhibitors. I can bounce at times quarters off of my patients. I put a drop in today. I kind of laughed. I said, I'm going to be talking about you tonight. I put a drop of fluorescent to someone's eye. And I usually say, hey, this is going to sting a little bit. It was a glaucoma patient. And she goes, I didn't feel a thing. I'm like, ooh, that's not good, right? Through my drops. But herpes and, drug toxicity is what I just covered. Ocular surgeries, there's a whole list here. The one I like talking about is diabetes. We always focus on the retinopathy, but doesn't diabetes cause neuropathy? Yeah, it does. Can it cause neuropathy to the eye? Absolutely. And it can cause a decrease in cornea sensitivity. So there's a lot of neurotrophic keratitis cases that are out there. Let me see here. Susan wrote, does medical insurance typically cover this? Yes, Susan, it typically does. They go through a whole process. They got a whole team set up. I think it's called Diplomate Connect. And like I said, I just start signing, send it in, and then the process starts. Usually takes about 3 to 4 weeks. So there's things that you can do in between, like Procaras and Regenerize, to kind of start setting that cornea up for success. That's out there. Joe, I see some replied something there. All right. So the assessment of cornea sensitivity is essential to confirm neurotrophic keratitis. So that's why we talked about cornea sensitivity and grading it. This is endogenous nerve growth factor to maintain the cornea integrity that's out there. It works for tear secretion. It works on cell proliferation and differentiation. You need endogenous. That means your body's producing it. Endogenous nerve growth factor is needed for corneal innervation, cell proliferation, and tear secretion. And this is what it looks like. This is what endogenous nerve growth factor looks like. And it's super important for the front surface of the eye. And that's when you start hearing like cytokines and different pro-inflammatory starts to now overtake, what the endogenous growth factor can do. And that's why there's Oxervate that is 0.002 It's a biologic that comes in this kit. You get 7 vial adapters, 42 pipettes, 42 disinfectant wipes, 1 dose recording card, and there's a few extra things thrown in there in case there are things that are dropped. Here's what's really, really cool. I love this slide here. This is endogenous nerve growth factor. And it's really complicated. It really looks like this over here, right? With all these twists and turns and so on and so forth. And this is endogenous. And Centergermin or oxervate comes out in this long chain. And I don't have any idea how someone figured it out, but they're able to twist that up to make it look exactly like endogenous growth factor. So it's truly a biologic that is being used. It's basically grown nerve growth or exogenous, nerve growth factor to help stimulate the eye and get that cornea back. So every 2 hours, 6 times a day for 8 weeks. I probably have done about 15 of these in my practice. So again, you got to grade the sensitivity. Is obviously if it's normal, you're not going to be able to do it, but it's absent, it's reduced. You're checking all the quadrants plus central, making that, and then grading your neurotrophic keratitis. And again, here's great cases that it can be used on. And this darn mouse is driving me crazy. All right, there it is. Again, this case and this case, I would still grade them grade 2. All right, so I think it was, who was it that asked? What about the feeling in the eye? I'm just kind of scrolling through here. I might have lost where that was. Oh, Jeffrey asked. So I'm going to play a couple videos here of patients that I treated here. Just kind of listen to this video here.
All right, here we are 1 week into Oxervate, and we have a patient that's going to give us her experiences of what's going on. So why don't you just jump into your list there and tell us what you got.
Okay, I've noticed that my eyes have become much more sensitive to the light. I barely need any tears at all. I've used them once a day, and one day I did not use any at all. My eyeballs themselves feel sore when you move your eyes or open and close.
So Jeffrey was asking the question. So it's kind of funny, right? My eyes feel better, but now they're sore. Which one is it? Come on. Get it. Come on, patient, get this right for us.
Eyelids. But I no longer have the sensation that there's something in my eye. They are very soothing.
So they feel worse, but now they're
Feel
soothing.
better.
Feel better.
And you're using what type of tears?
I'm using Refresh Optive. Usually I finish the eye drops, the last one for the day is at 6:30 in the evening, and usually by 9 or 10 o'clock I use 1 drop of the Refresh Optive, and that's all I need.
And that's the preservative free, right?
Yes.
Okay. So 1 week into it, not doing too bad, getting some sensitivity back to your eye. Putting a drop in every 2 hours, 6 times a day. We're 1 week into the 8 weeks. Things seem to be going well. Do you agree with that?
Yes, I do.
Okay. We'll check back next week. And then.
All right, we'll play now 3 weeks. I did check her at 2 weeks, but here's 3 weeks.
All right, here we are with our weekly follow-up with our patient. We have time 0 up here, and then we have a week after Oxervate, and then 2 weeks, and you can see we had a nice
Pretty cool right
improvement
there.
today with the SPK with Oxervate. So let's swing over here to our patient. And how's there any difference between last week and this week, or since we started?
The biggest difference is I can now read. Any time of the day I would choose. I can see clearly, and it's a big improvement. And my eyes feel good.
The eyes feel good.
Yes.
It was, so other than that, you said there's really been just status quo since last week.
Yes,
is that correct?
the still a little bit of discomfort, nothing bad.
Good.
And I'm very happy with it.
Good.
Okay, here we are, week 6 tomorrow. We'll finish up week 6. There's our beginning, all the SPK, just a little bit of SPK up top. Obviously, the right eye was the worst side. You can see the SPK starting 6 weeks ago, and just a hint of this keratitis up here towards the top. Week 6 here with Joy, and tell us what you got. You were telling us about how it's nice to wake up in the morning.
I get up, my eyes do not hurt when I get awake. I don't need any refresh immediately. In fact, I think in the past week I've only used refresh 2 times at bedtime. My husband has enjoyed the eye drops coming in dry ice. He has used it to make ice cream.
That's a maybe an off-label use of the dry ice, but
Dry ice. But
but definitely a benefit.
yes.
We're not I guess responsible for any weight gain for him. So tell me about the vision. Have you noticed anything with your vision?
My vision is much better. I can read without difficulty, play the piano. When I'm driving, I can see the signs without having to be really close to them. It's just made a real world of difference.
All right, and we were explaining that that's because she had all this SPK over the center part of her pupil there, and now that it's clear, she's able to see a little bit better. So, been a good.
So yeah, it's a pretty cool medication. It does, in my opinion, need some maintenance sometimes after, even though 80% of the patients a year out were healed. I still like to cover them maybe with maybe ACED, the tears that are out there, like vital tears, maybe a 20% up to 50%, depending on how severe it was. They can't get it into 100% now. But maybe in a condition, maybe 40% like this, maybe to start off and wean them down to 20%. Autologous serum eye drops is what ACED is. Now I go back to the question of Jeff here. It was really all the patients that I had. They all come in and say, "Oh my gosh, my eyes feel better." Than it's like almost seconds later they say, "But my eye hurts." And I do a pain medication or pain with opioids. And this is the best scenario that I can have, is that there's just not one type of pain fiber, right? If you hit your hand with like a hammer, it throbs, it's acute pain. There are different types of fibers, pain fibers. So I think some are coming alive, some are firing. And so that's why, oh, geez, my eye feels better, but yet I still feel something happening that's out there. Kind of like when you cross your leg and it falls asleep, and then your leg hurts like crazy as the blood flow starts to go down through there. So I think that's probably, Jeffrey, that's probably the best way to handle it, is to say, hey, look, your eye's coming alive, it's feeling better. That's the way all these patients, I had 15. They all say that it feels better, but they still feel pain in their eye, but yet it feels better. So maybe it's a good pain that's out there, kind of like working out. All right. So, the study conclusions with this after 8 weeks of treatment, there were 50 clinical trials, between the United States and Europe. There's different studies. I'm not going to dive in. This is not like a dinner program. So we're just going to talk about 72% were completely healed. And then you can see of the patients who were healed after 8 weeks, 80% still remain. So I've had a handful of patients that I had to do a retreatment, and I had another patient that I did a third treatment on, and she's finally there. And it kind of goes up to the question that rolled in with Kurt is, does graft versus host disease create neurotrophic keratitis? And I have a graft versus host in one eye, very asymmetric, and we were able to use the oxervate, but it was 3 times there, Kurt, to get that one to heal up, because it's a little bit different. And she turned into a pirate fan. You're absolutely right there. Can oxervate for post LASIK? Absolutely, it can be used as long as you document that there's keratitis and that it's a desensitized cornea. Can oxervate be RX later in date if it returns? Absolutely, Charles. It can be. I've done them as close to probably 4 months apart, and I've done them as far as a year apart. So it could be used again. Key is documentation, right? You got to do cornea sensitivity testing. You got to grade the keratitis that's there. But it can be, and I have a patient, like I said, that I've used it 3 times. I have one patient 3 times. So adverse reactions, very well tolerated. Most common adverse in the clinical trials. Look, eye pain. I think it makes sense. They're neurotrophic. You're bringing it back. Corneal deposits, foreign body sensation. Again, bringing it back. Ocular hyperemia. Nothing really big here. It's endogenous growth factor in a biological way. Really, no one's going to be wearing contact lenses. So this really goes on every kind of package insert. I mean, they're putting it in every 2 hours. They'd be putting a lens in, taking it out. Plus, we're trying to heal the cornea. Contact lenses create desensitizes the eye. And the molecule is super, super sensitive. I don't really use anything else in the eye unless it's an infectious keratitis, and we're trying to use it for an infectious keratitis. So, Joe, I think instead of getting into thyroid eye disease, I think, talk about Tepezza. We'll save it maybe the best of the rest, maybe for another anterior segment. I was going to talk about Tepezza, but you mentioned about a couple clinical pearls. And then we'll just wrap this up and maybe do another anterior segment.
Okay, I'm gonna share my screen then. I'm just gonna wrap this up real quick. I think it will help everybody. That's not what I wanted. So a couple of things to remember: when in doubt about the cornea, presume that it is herpes, unless it isn't. And here's the case what I call the herpes that wasn't. It's going to be very quick. I think you'll probably encounter this at some time. It is not uncommon. I mean, Greg, it might be a little uncommon where you are right now. It is not uncommon, but it will help you if you recognize this. She's a 63-year-old female who had a sudden onset of blurred vision for about 2 days, not getting better, a little bit of discomfort. She's 2200 in this eye. There's a rare cell or 2 in the anterior chamber. The epithelium is intact, but she has profound corneal edema and folds in Decimase membrane. Now, this is in our practice. My wife saw the patient, and she was suspecting that there is a herpetic issue, a herpetic endotheliitis. When in doubt, always think herpes. If we got a funky cornea, alien keratopathy, always think herpes and consider maybe a Valtrex. Now, that was her suspicion. She put the patient on Valtrex, and she was telling me about it at home that night. And now this is a nice example of what we're looking at here. You got the folds in Decimase membrane, highly inflamed, a lot of really dense central corneal edema. The epithelium is largely intact. What about that history? And she's telling me about it. And I said, give the patient a call and ask her if she's a lepidopterist. Now, when she calls the patient, I can overhear the conversation. And she was an amateur lepidopterist. And a lepidopterist is a person who likes butterflies and cultivates butterflies. Now, I like to do it myself. So I consider myself a lepidoptometrist. I think that's a unique word. And what happened was, you say, yeah, she was redoing all her milkweed. And turns out she got that in her eye. This is what we call milkweed toxicity. It is very, very characteristic. Now, the monarch butterflies, they're poisonous. If something ingests them, they're going to get sick. And the reason that happens is the larvae, the caterpillar, eat milkweed. Milkweed is a toxin. It produces carnitinides, which are cardiac glycosides, very similar to digitalis. They're going to bind to the sodium-potassium pump, and ocular exposure is going to shut down the sodium-potassium pump, corneal edema, some ocular irritation. It's going to give you folds in Decimase membrane, but largely an intact epithelium. So whenever you see that profound corneal edema and folds and decimes and the good intact cornea, ask about butterflies and weeds, any handling plants. I can't tell you how many of these patients that I've had, I almost consider this to be an existential crisis. So always consider milkweed toxicity. It's very, it's almost like a digitalis toxicity. It is very specific, very dense cornea, epithelium is intact, folds and decimes. You ask the history, there's your answer. Now, if you don't have that history, you got to consider it might be herpetic. Greg, any thoughts there? Because I have one last real quick clinical pearl.
Yeah, do the last clinical pearl.
Okay, Greg, I had a patient today, 14-year-old male. Yesterday, he was at school. One of his classmates noticed his pupil was dilated, and he noticed that his vision was blurred in one eye. Went to the school nurse. They saw his pupil was dilated. They shifted him off to his mother, who took him to the emergency room. They're there till about midnight, getting a CAT scan, serology. Fortunately, nobody did a lumbar puncture on him. He comes in today, and he's got pretty much about 4 to 5 millimeters of anisocoria, nice round pupil, beginning to react a little bit. No afferent pupillary defect. That really smells of something that is pharmacologic. So we go through the history. It turns out he's using, and you all may want to write this down, Quebrexa, Qbrexa. It's glycopyrronium topical wipes or hyperhidrosis. It is an anticholinergic agonist. Or antagonist. Essentially, this is scopolamine for the new generation. You know how people use the scopolamine patches that come in with a dilated pupil? Qbrexa. I've seen several of these. I think it's a relatively newer medicine. It's kind of expensive. It's $580 for 30 wipes. They wipe their armpits if they are excessively sweating. So glycopyrronium Quebrexa, think of that or write that down somewhere. If you get a person who's got a fixed dilated pupil, you're dealing with a pharmacologic misadventure. It's not always going to be promotion sickness. It's not always scopolamine. We can have this other anticholinergic agonist. So just a couple quick pearls of the odd things that are very specific, and we have a definite diagnosis for both of them.
Joe, would you mind typing that maybe into the to the chat box?
Yeah. Yep.
And people can then see it there.
Mm-hmm.
And then there was a question that came in, the last question, it looks like, do they have to remove their RGPs before the use? I would not want them using, Charles, the RGP contact lens. I mean, maybe I guess if it's keratoconus or they have to be able to see, that's the only way. But I don't, the medication, all biologics are super sensitive. So I don't like any chemical going into the eye. I really wouldn't want a mechanical irritation of the contact lens. So even though it might not build up into the contact lens, it might not allow the efficacy of the oxyrvate. So I would at least say to the patient, remove that contact lens 15 minutes before, maybe not for absorption reasons, but to allow that medication to be as effective as possible. All right, so we've got a couple people say milkweed. Spell that again. Joe's typing it right now. So with that being said, it looks like all the questions are cleared up here. So I'd like to thank everyone for attending Anterior Segment Grand Rounds, the best of the rest. Truly an honor for Joe and I to bring this course to you tonight. We hope you enjoyed it. Joe, before we end the CE, do you want to make any comments?
No, I think we really appreciate everybody showing up to our webinar series. We always have a nice crowd. Everybody is engaged. A lot of really great questions. It helps us. It's nice to be able to bounce it back and forth with Greg and not just one personally prattling on, not sure if anybody's out there listening. So we really enjoy doing this, and we plan to do this into the new year as well.
And I was looking at this clock the other day when I took this in the office. This is a Shoreview clock. Shoreview, guys, when Shoreview was a lens, and it's still working.